Hey everyone, today I'm going to be presenting our outcome measures project, the modified Oswestry test, and the timed up and go test. This PowerPoint is presented by Bailey Turdbill, Christian McElvin, and Isabella Vining. First we're going to look at the modified Oswestry test. The modified Oswestry test is considered the gold standard of functional outcomes for lower back pain. This is a self-reported outcome measure, which means it gives us an idea of the patient's point of view of their abilities. The purpose is to objectively measure a patient's current level of function related to low back pain and how this pain affects their daily lives. This establishes a comparative baseline for future testing to determine if therapy was beneficial. The target population are individuals ages 18 to 65 or older with lower back pain. The ICF domain is body structure, body function, activity, participation, and environment. The areas of assessment are activities of daily living, functional mobility, gait, life participation, occupational performance, pain, quality of life, seating, self-efficacy, sleep, and social relationships. This is a display of the test that is given. The survey is given to patients for the modified Oswestry test, and each of the 10 of the categories is broken down into 6 questions. So how is it performed? The instructions to give the patient are to instruct the patient to read from the form and answer to the best of their ability, or to offer to read the form to them and have them answer it out loud. The materials needed are the survey, the writing utensil, or a telephone if it is being administered over the phone. There's no training required, and the time required to administer the test is 3.5 to 5 minutes total. An additional minute is typically required to score the survey. Next, how is it scored? Each section consists of 6 statements. Each statement is associated with a number ranging from 0 to 5. Depending on which statement the patient selects, scores are assigned to each section. The score from each section is added together, and the total score is divided by 5 times the number of items answered. This total is then multiplied by 100 to get a percentage. When looking at the scoring, which ranges from 0 to 100%, if the patient scores between 0 and 20%, they are considered to have minimal disability. No treatment is necessary. You can offer advice on possible modifications to activities. If the patient scores between 21 and 40%, they have a moderate disability. They will have management by conservative means. If the patient scores 41 to 60%, they are considered to have a severe disability. Their pain affects normal activities, and further screening and questions are required. If the patient scores between 61% and 80%, they are considered crippled. All ADLs are impacted by the individual's back pain, and they require interventions. If the patient scores between 81 and 80%, 81 and 100%, they are considered bedbound. Next, we're going to look at psychometric properties. Interpretation of change over time. There's minimal clinical important difference between 4 and 10.4 points. It has a relatively high responsiveness, so it can interpret change over time. When looking at measures of reliability, it has acceptable internal consistency, high test-retest reliability. Researchers conclude that this test is reliable for clinical practical purposes. And while the questionnaire is broad, it is a good place to begin to assess functional limitations in patients with low back pain. When looking at test validity, the convergent validity was tested in one study using the Dutch version of the ODI. This is essentially the modified Oswestry test modified for Dutch culture. This study looked at convergent validity of this test compared to the SF36 and RMDQ, and moderate negative correlations with the SF36. This study looked at construct validity as well, and they found that people marked improved on the GPS also found reduced disability on the questionnaire. Next, we're going to look at the timed up and go test. The timed up and go is a performance-based outcome measure. The purpose of this test can be used to assess mobility and balance. The target population is typically older adults, 65 and older, potentially at risk for falls. The ICF domain is activity, and the areas of assessment are balance, vestibular and non-vestibular, gait, and functional mobility. Here's a video that displays how to do the timed up and go test.
We're going to be looking at the timed up and go test to assess fall risk in the elderly population. welcome back to Physio Tutors. The Timed Up and Go test has been rated both 87% sensitive and specific in identifying elderly who are at risk of falls in a small-scale study done by Shumway-Cook et al. In the year 2000. To conduct the test, you need a chair, a stopwatch, and some tape to mark a line on the ground 3 meters away from the chair. To conduct the test, have your patient sit on a chair with possible walking aids at hand. Then explain the procedure to your patient as follows. When I ask you to start, please get up from your chair and walk at a comfortable and safe pace to the mark 3 meters away from you. Cross the line, turn around and return to your chair and sit back down again. Could you repeat that to me? If your patient has understood the process, ask the patient to start the test. Once you ask the patient to start the test, you will start the stopwatch and only stop it until the patient is seated again. Okay, Kai, you may start. The patient is allowed 1 practice round and 1 round is timed. Amongst other risk factors, such as a history of falls, poor vision or certain medications, a time of 14 seconds or more during the Timed Up and Go test, or if your patient appeared unsteady, could indicate a higher fall risk.
Okay, let's review how this test is performed. Instructions to give the patient are to demonstrate the test to the patient prior to having them perform the test. Then you're going to instruct the patient to stand from their chair, walk at a comfortable speed to the marked place on the floor, turn around, and return to their seat and sit down. They're allowed 1 practice trial, and then 1 trial is timed. The materials needed are a chair, stopwatch, and then something to mark the 3-meter distance. There's no training required, and the time to administer the test is usually less than 3 minutes. So how is it scored? The time it takes the patient from go to the patient returning to their seat is measured in seconds. Generally, the faster time on the tug is indicative of a higher level of mobility and a lower risk of falls. Over time, you can compare the patient score to determine if performance has improved. For the interpretation of scores, less than 10 seconds or equal to 10 seconds is considered normal. Less than or equal to 20 seconds is considered good mobility, and the patient can independently leave their home without the need for an assistive device. Less than or equal to 30 seconds equals a problem with mobility. Patient requires the use of an assistive device. If it's greater than or equal to 14 seconds, they show a high risk for falls. Looking at psychometric properties, interpretation of change over time, minimal detectable change for patients with Alzheimer's disease is 4.08 seconds. Minimal detectable change in patients with Parkinson's is 3.4 seconds. Measures of responsiveness over time showed moderate effect sizes in ADL decline, with a small effect size for both falls and ADL improvements. Measures of reliability. The test-retest reliability showed that the test was consistent in patients with Parkinson's. There were several retests had the exact same result, or 1/10 of a second difference. Excellent retest reliability in patients with Alzheimer's disease showed a correlation coefficient of 0.987. Inter-rater reliability was good for adults with various conditions. For test validity, looking at content validity, TUG was modified from the Get Up and Go GUG measure. Modifications were made to the GUG to improve validity and to create the test that we use today. For convergent validity, the TUG has been shown to have moderate to strong correlations to the ABC outcome measure. Adequate correlations when comparing TUG to Tonetti balance, Tonetti gait, walking speed, and ADL score were shown. For sensitivity and specificity, according to one study, TUG showed an 87% sensitivity and an 87% specificity. These percentages were based on how well the TUG identified fallers from non-fallers. While these numbers may not be applicable to all scenarios, they do give a good indication that TUG is a good test for the identification of potential fallers. For floor effects, in older adults and acute patients, there are poor floor effects. Here we have our references if you want to look up any additional information on these 2 tests. And here's another set of references, and that concludes our presentation on the modified Oswestry test and the TUG test. Thank you.